Hi guys, let us continue with our topic HIV. In the last section, we went into the pathophysiology. You have seen the life cycle of HIV and its clinical presentation. Anyway, today let us continue with treatment for HIV. In deciding to initiate the antiretroviral therapy, it is important to consider both the potential benefits of the therapy and the potential risk of the therapy, including both the short-term and long-term side effects and potential for the development of drug resistance. Antiretroviral therapy should be offered to all patients who are willing and able to commit to lifelong treatment after an in-depth discussion of the benefits and risks of the heart. So heart is nothing but the highly activated antiretroviral therapy and the importance of adherence. So when we are treating a HIV patient, we should counsel them regarding the importance of drug adherence as well as the benefits and the risk of the heart. The decision to initiate the therapy should not be taken lightly. Antiretroviral regimens may improve the quality and the duration of a patient's life, but they are not without risk. Once therapy is initiated, antiretroviral therapy is a lifetime commitment. For some patients, this may be a difficult realization, particularly if the patient is relatively healthy. In addition, the risk of adverse events or toxicities and the cost of heart should be considered before beginning therapy. Now, let us take a look at the goal of the treatment of HIV. So, what should be the main aim? To decrease morbidity and mortality. By successfully treating HIV, that is, suppressing the viral load and restoring the immune function, patients are at decreased risk for acquiring HIV associated opportunistic infections. Okay, then another important goal is to improve the quality of the life. And next one is restore and preserve the immune function. So how we can restore and preserve the immune function? We can decrease the viral replication, which usually leads to increase the CD4 cell counts, which strengthens and preserves the immune system. So with increased cell counts, patients are at lower risk for exhibiting opportunistic infections and death. Then the last and the most important goal is to prevent further transmission through maximum suppression of HIV replication. Now let us take a look at the general approach, how we can manage HIV. Initiation of the therapy should occur soon after diagnosis in most patients. Many of the current regimens reduce viral replication to less than detectable levels and result in durable treatment responses. Reasons for the current improved response rates include the simplification of the regimens, then improvement in overall potency of the regimens, and also the minimization of short-term side effects. Consequently, if the correct patient-specific heart regimen is selected as initial therapy, the patient should be able to adhere to therapy and gain both virologic and clinical benefits from the regimen. So there exist mainly 4 primary groups of drugs, that is antiretroviral agents. Those are entry inhibitors, reverse transcriptase inhibitors, which include 2 types, NRTase and NNRTase, that is nucleoside reverse transcriptase then non-nucleoside reverse transcriptase inhibitors. Another one is the integrase strand transfer inhibitors INSTIs and HIV protease inhibitors PIs. So the most important step is to select the type of antiretroviral regimen. In general, PI based or INSTI based combination heart are preferred. So here you can see where these inhibitors actually acts. So you can see the entry inhibitors, which inhibits the entry of viral genome into the host cell, whereas reverse transcriptase inhibitors inhibits the enzyme reverse transcriptase, thereby inhibiting the transcription of RNA to DNA. Whereas the integrase inhibitors inhibits the integration of the provirus into the host cell genome. And the last one, that is HIV PIS, that is HIV protease inhibitors. So they inhibit the synthesis of HIV proteins, thereby inhibiting the assembly of the virion particles. Now you must have understood the places where these drugs actually acts. Now coming to the pharmacologic therapy, treatment of human immunodeficiency virus infection, antiretroviral regimens recommended in antiretroviral naive persons. So these are the regimens which are based on the inhibitors such as entry inhibitors, reverse transcriptase inhibitors, INSTAs, then PIS. So let us look at the preferred regimens. So first of all, NNRTI based, that is non-nucleoside reverse transcriptase inhibitors based preferred regimens are efavirenz, tenofovir and emtricitabine, whereas HIV PI based regimens are darunavir, ritonavir, tenofovir and emtricitabine. Also there is another regimen which is atazanavir, ritonavir, tenofovir and emtricitabine. And finally INSTA based regimens are raltegravir, tenofovir and emtricitabine. So when there is a potential disadvantages, we can use alternative regimens such as NNRT based alternative regimens are efavirenz, abacavir and lamivudine, rilpivirine, tenofovir, emtricitabine, then rilpivirine, abacavir, lamivudine. And HIV PI based alternative regimens are atazanavir, ritonavir, abacavir, lamivudine, darunavir, ritonavir, abacavir, lamivudine, then lopinavir, ritonavir, either with abacavir, lamivudine or tenofovir and emtricitabine. Also there is another regimen which is fosamprenavir, either with abacavir, lamivudine or tenofovir and emtricitabine. And INSTI based are raltegravir, abacavir, lamivudine and elvitegravir, cobicistat, tenofovir and emtricitabine. So their limitations are also listed here. And another acceptable regimens are these are considered when there is potential additional disadvantages or pending additional data. So NNRT based regimens such as efavirenz, sidovudine, lamivudine, nevirapine, sidovudine, lamivudine or tenofovir emtricitabine, nevirapine, abacavir, lamivudine, rilpivirine, sidovudine, lamivudine can be used. Then HIV PI based combinations regimens such as atazanavir, abacavir or sidovudine and lamivudine. Then fosamarinavir, ritonavir or atazanavir, ritonavir, sidovudine and lamivudine. Then dranavir, ritonavir or lopinavir, ritonavir plus sidovudine and lamivudine. So these are the HIV-PI based preferred regimens. Then CCR5 inhibitor based, that is the chemokine receptor inhibitors. They are maraviroc, sidovudine, lamivudine, then maraviroc, tenofovir plus emtricitabine or abacavir and lamivudine. Then INST based drugs such as raltegravir, sidovudine and lamivudine. So the regimens and components that should not be used as initial therapy, that include any all NRTI regimen, then lamivudine or emtricitabine and didanosine plus tenofovir, stavudine. So these should not be used as a initial therapy. And the following drugs are dranavir, fosamarinavir, swakinavir or tipranavir without ritonavir. Then delavirdine, enfuvirtide, etravirine, indinavir with or without ritonavir, nelfinavir without ritonavir at virologic doses, tipranavir, ritonavir. Now let us take a look at the selective pharmacology characteristics of antiretroviral compounds, drug bioavailability and elimination half-life in adult. So here are the list of the drugs. First of all, let us look at the integrase inhibitors. So here is elvitegravir and raltegravir. So integrase inhibitors are well tolerated drugs and single tablet regimens are available with EVG and DTG. Then fewer drug-drug interactions with RAL and DTG than PA or NNRJ based regimens. So you can see there is few drug interaction with these integrase drugs, and it achieve rapid viral load suppression. So these are the advantages of integrase inhibitors. In addition to this, there is also disadvantages such as it is having less long-term experience than with boosted PI based regimens, and also it have lower genetic barrier to resistance than boosted PI based regimens. And the next one is the nucleoside or nucleotide reverse transcriptase inhibitors. So those are abacavir, didanosine, emtricitabine, lamivudine, stavudine, tenofovir and sidovudine. So here you can see the bioavailability of the drugs clearly, also the half-life of the drug. In case of the integrase inhibitors, bioavailability is not recorded, and these NNRTs are having long half-lives. So you can see the half-lives are long when compared to the integrase inhibitors. So this there are also single tablet regimens are available, but there are disadvantages such as it is having low genetic barrier to resistance, then cross resistance among first generation NNRT, then skin rashes there, Then potential for cytochrome P450 drug interactions. So in this NNRJ you can see drug interaction with P450, cytochrome P450. Then transmitted resistance to NNRT is more common than with the PIs and INSTIs. Then next one is the non-nucleoside reverse transcriptase. So this one include dilaberdine. For this NRTs, these drugs are having less fat maldistribution and dyslipidemia than the PI based regimens. So before what I told is for NNRTIs, okay, that is for NNRTIs it is having long half lives and single tablet regimens are available, okay, whereas for NRTIs this is the backbone of the combination of antiretroviral therapy, okay. Then next one is the efavirenz, etravirenz, nevirapine, rilpivirine. These all are related to the NNRTIs. Now coming to the protease inhibitors, which include fosamarinavir, atacinavir, darunavir, indinavir, lopinavir, nelfinavir. So these protein inhibitors are having higher genetic barrier to resistance. So there is no PI resistance, that is boosted PIs are not needed. So PI resistance are uncommon with failure. Then more forgiving to intermittent adherence. Then there is also disadvantages such as metabolic complications, that is fat maldistribution, dyslipidemia, insulin resistance. This all can be seen with the use of protease inhibitors. Also cytochrome P450 substrates inhibitors and induces. So for with them you can see the potential drug interactions. And the remaining protease inhibitors are ritonavir, saquinavir and tipranavir. And the last one is the second last one is the entry inhibitors, fusion inhibitors. So the drug is enfuvirtide. So this drug inhibits the entry of the viral particle into the host cell as well as its fusion. And another one is the co-receptor inhibitor. So it is nothing but the CCR5 inhibitors. They are maraviroc. So this helps in the prevention of attachment of the HIV particles into the host cell. Now let us take a look at the treatment during pregnancy. In general, pregnant women should be treated like non-pregnant adults with some exceptions. Efavirenz should be avoided when possible in pregnant women during the first trimester or in women trying to conceive because of potential teratogenicity. So generally we should avoid efavirenz in case of the first trimester or in the woman who is trying to conceive, because this efavirenz is having the nature of teratogenicity. Drugs that cross the placental barrier should be avoided, such as abacavir, emtricitabine, lamivudine, tenofovir or sidovidine. So these drugs should be avoided in the pregnant woman. Intravenous sidovidine is recommended intrapartum depending on the mother's viral load, based on early studies demonstrating clear prophylactic effectiveness as well as extensive familiarity with the side effect profile. So intravenous sidovidine is recommended as the prophylaxis for intrapartum for which is based upon the mother's viral load. Infants also receive pseudovirine prophylaxis for 6 weeks after birth. So, following the birth, we can provide pseudovirine for the infants at least for 6 weeks. Then post-exposure prophylaxis. Post-exposure prophylaxis with a triple drug regimen consists of 2 NRTIs and a boosted PI is recommended for percutaneous blood exposure involving significant risk, that is large bore needle or large volume of blood or blood from patients with advanced AIDS. So for the post-exposure prophylaxis, we can use a triple drug regimen which is having a combination of 2 NRTIs and a boosted PI. Then 2 NRTIs may be offered to healthcare workers with lower risk of exposure, such as that involving either the mucous membrane or skin. Treatment is not necessary if the source of exposure is urine or saliva. So we can offer the 2 NRTI combination for the healthcare workers with lower risk of exposure, such that if they are exposing of their mucous membrane or skin, we can prevent the spread with the help of 2 NRTIs. The optimal duration of treatment is unknown, but at least 4 weeks of therapy is advocated. So this post-exposure prophylaxis duration is not actually known, but we have to continue the treatment for at least 4 weeks. Ideally, the treatment should be initiated within 1 to 2 hours of exposure, but the treatment is recommended for up to 72 hours post-exposure. So once if we expose to the HIV, then the treatment should be initiated as soon as possible, that is within 1 to 2 hours of exposure. But in case if it is delayed, the treatment can be taken up to 72 hours of post-exposure. So this is all about the management of HIV. Hope you all understood. Thank you.